Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
So we're going to talk about movement disorder and seizure disorders. They both are very vast entities and subjects. It takes them, we can take so much time talking about them extensively. So I'm going to go first about movement disorders and then seizure disorder. What is considered as a movement disorder? Any part of the brain that deals with movement, if that is involved, then there can be a movement disorder. There are certain parts of the brain that deal with movement, such as basal ganglia and cerebellum. I'll be showing you some pictures of those later on. So anything which is causing some problem, which that particular part of the brain can cause a movement disorder. There are various diseases which come under movement disorders. The main one is Parkinson's disease. And we're going to talk extensively about Parkinson's disease, the diagnosis and treatment. And the second one is tremors. Dystonias are the painful movements. They're like spasms of the upper or lower extremities. Some people have cervical dystonias, which is a very common condition also. Chorea comes from Huntington's disease. Cerebellar ataxias are the disorders which are mainly genetic disorders. The genes are not developed right. Cerebellum, which is the back part of the brain, does not develop right, and people can have movement disorders. Tourette syndrome, blepharospasm means very painful, and squeezing of the eyelids of the eye can cause a spasm, and that can cause a irregular movement of the eyelids, which is also considered a movement disorder. And so is hemifacial spasm. One part of the face can go into spasm real bad and causes some tingling and movements of the face, also part of it. Myoclonus is just a jerking activity of the whole body. Restless leg syndrome is when there's a lot of tendency for the patient to move their legs and they do not get satisfied till they really move the leg. So that is another entity under movement disorders. Dyskinesias are due to certain medications which we use for Parkinson's disease, or there are other medications for psychiatric disorders which can cause a specific term called tardive dyskinesias. So let's talk about Parkinson's disease first. As you know, it's described first by a person named James Parkinson. And actually he wrote an essay. It's called Essay on a Shaking Palsy. So they have patients who are having symptoms of Parkinson's disease, and he described them first of all in the literature, and then the name came after him as Parkinson's disease. When we classify Parkinson's disease, there are different kinds of classifications. The first is considered as a primary Parkinson's disease. That means there's a degeneration going in the brain. Degeneration means the cells in the brain, they are not functioning well, or they're reduced, or they're dying for some reason. So they're not producing a certain kind of hormone, or we call them neurotransmitters in the brain. In case of Parkinson's disease, it's called dopamine. So there's a lack of dopamine in the brain cells because there are not enough cells to produce dopamine. So Parkinson's disease is one of the primary degenerative disorder. The other example is Alzheimer's disease. Same thing happens in Alzheimer's. The cells are not there. They're not producing certain neurotransmitter, and that causes lack of acetylcholine and gives a patient symptoms of dementia, which is memory loss. There are other diseases which a patient can have Parkinson's disease, but they also have other symptoms, such as, I have listed them, MSA, stand for multi-system atrophy. So not only the cells which produce dopamine is affected, but other cells in the brain, they are also affected, and their patient is going to have symptoms of Parkinson's as well, other symptoms such as difficulty with your cognition and memory. PSP stand for progressive supranuclear palsy. In this entity, a patient can have Parkinson's disease and difficulty with upward gaze. They cannot look upward, and they have difficulty in standing up when they get up from the chair because their blood pressure drops. CBD stands for corticobasal degeneration. DLB is considered as dementia of Lewy body, and PDD is a Parkinson's disease of dementia. So all this CBD, DLB, and PDD, all their patients, they do have dementia. They have memory problems. They have other features along with Parkinson's disease. So when somebody has Parkinson's disease feature, we need to rule out, is it just a Parkinson's disease, or they are having other diseases along with Parkinson's. We're talking about symptoms of Parkinson's disease. I will consider tremor as the main feature. If anybody has a tremor, they always get concerned if they have Parkinson's disease. And I do see so many patients in my office because they're having tremors, and the fear is that they are going to have Parkinson's disease. But that doesn't mean that each tremor, if somebody has, is going to be a Parkinson's disease. Tremors can be from various reasons. There are multiple causes for tremors. But that fear is always there when somebody develops a tremor, that maybe they have Parkinson's. The tremor in the Parkinson's disease is quite specific. It's called a resting tremor. A resting tremor means the patient is resting, they're relaxed sitting in the chair, or they're lying in the bed. They are not performing any activity, and they're having a tremor. Usually it happens on one side of the hand, then it can go to the other side of the hand, other left side or right side. It can also involve lower extremities, which is legs. It's considered as a pill rolling tremor. So it's like as if you're rolling a pill between your thumb and index finger. So this is a characteristic tremor of Parkinson's disease called pill rolling tremor. Usually the tremor will go away when the patient is sleeping or they are completely relaxed. The next feature I will talk about is rigidity. Rigidity means muscle stiffness. The body is very stiff. It's very difficult for them to get up or walk around because the joints and the muscles, they are very stiff. There's a specific name for that rigidity. It's called cogwheel rigidity. It's just like a clasp knife. If somebody's opening a knife and you feel the resistance, similarly, if somebody has Parkinson's disease and they are very rigid, if their arm is flexed, I have to pick it up and open this arm here. It will be a cogwheel rigidity. There'll be a lot of resistance to it, just like opening a knife. Bradykinesia, akinesia are the other terms used when there's a difficulty in initiating a movement, such as patient may have difficulty getting up from the chair, getting up from the commode, getting up from the bed. And at times, it can be a difficulty moving your body from one side to another. So you take a turn in the bed, it's very difficult for the patient to turn to one side and then turn to the other side. Any kind of initiating a movement can be a problem. This is because the movements are so slow down. Akinesia means no movement. So sometimes the patient will get up from the chair and they want to initiate a walk, but then they freeze. It's very difficult for them to take a step. Postural instabilities are difficulty with maintaining your posture. So there is a very much tendency for falls. There's an imbalance because the muscles are very stiff and there's a difficulty with balancing itself. Gait disorders are with walking, the patient, the way they walk. There's a specific posture they can have, that their bodies are flexed and they're shuffling their steps and they're stooping over to prevent the fall. So when initiating the gait, there may be difficulty. Once they are into that process, they are very much concerned that they may not fall. So they physically, they're like this, shuffling and trying to prevent the fall. Other is decreased movements of the other parts of the body, such as the facial musculature. There's no expression on the face. We call this mask-like faces. The blink, the eye blinking is very delayed. The swinging of the arm. So some people, they notice these features themselves, or their loved ones will be noticing these symptoms, and they would like to get them evaluated to see if they have Parkinson's disease. Difficulty with swallowing, because the swallow reflex is delayed. A patient cannot retain their own saliva because they have difficulty in swallowing their own saliva, so there's a lot of drooling going on. Other features can be micrographia, as the handwriting becomes very small, especially for Parkinson's disease. These were the motor symptoms when you're performing something and there's a problem. We talk about neuropsychiatric symptoms. Memory problems is considered part of Parkinson's disease. Like we discussed, some people have Parkinson's disease and dementia. So it becomes very difficult to check those patients also, whether it's just a Parkinson's disease or they're having other parts of the brain being involved, causing memory issues. Depression and anxiety can be due to the disease, or because the patients are so much concerned about their disease, that also can lead to depression. Hallucination, psychosis, some suspiciousness, some paranoia, seeing things which are not there is more common than hearing things. Some hallucinations can be due to medication side effects also, which we're going to go into that more details a little later. Autonomic dysfunction. The brain has central nervous system, which is the brain. Peripheral nervous system is considered as nerves and the spinal cord. And there's a third system called autonomic nervous system, which is control the blood pressure and heart rate. So all those things are controlled by autonomic nervous system. Some patients, they do have difficulty in their blood pressure, because when they get up from the chair suddenly, or from the bed, they may fall because their blood pressure drops. Oily skin, difficulty with controlling the urine and the bladder, sexual dysfunctions. These are considered under autonomic dysfunctions from Parkinson's disease. Patient may have difficulty in sleeping, or they may sleep excessively during the daytime. So it can be either side. Constipation is quite common. Now we're going to talk about causes of Parkinson's disease. Like I discussed before, idiopathic means unknown cause. That is a main part of Parkinson's disease called primary Parkinson's disease. We do not know that why the brain cells die, and which patient is going to have loss of cells is not predictable. But there have been some research, and we think some of the cases are some genetic, because there has been genetic mutations, and maybe 15 to 20% of patients, they do get some genetic predisposition, they run in the families. Other research have shown that some environmental toxins, such as pesticides, has been related to some cases of Parkinson's disease. Similarly, use of rural well water also considered cause. Certain kind of toxins, excess of magnesium, iron can be also related to that. Now we're going to talk about secondary Parkinson's disease, which we know that there are some things which can cause Parkinson's disease, such as head trauma. If somebody has a massive head trauma in certain part of the brain, there's an 8-fold increased incidence of having a Parkinson's disease. Other entities, cerebral anoxia. If somebody has a breathing, they are having difficulty in breathing, and they go into a respiratory distress, they are not breathing properly, their heart stops, their breathing stops. We call it cardiopulmonary arrest, that the heart and lungs are not functioning properly, and they pass out. So they come to the hospital, they're on the ventilators. So if once the patients survive, and they may be considered having anoxic brain damage, means there's a lack of oxygen to the brain. And the certain parts of the brain, they cannot withstand any lack of oxygen. And basal ganglia is considered one of them. If there's no oxygen to the brain, that part of the brain gets destroyed. The cells, they do not function. And once the cells in the brain, they're destroyed, they cannot be replaced. That's considered as permanent destruction of that cell. It's very commonly we have seen people who have carbon monoxide poisoning, that you can see on the scan there will be a effect on the brain in basal ganglia showing that there is a part of the brain that has been destroyed. So that can lead to Parkinson's disease. This is considered as a secondary causes. This is not the primary disease itself. Drug-induced Parkinsonism is called Parkinsonism because it's not like Parkinson's. It's also considered pseudo-Parkinson's because there are medications they are given. They cause symptoms of Parkinson's disease, and they are not permanent symptoms because some of the medication, when they are taken away, then the Parkinsonian features, they also go away. In drug-induced, it's very common medication which I will say used for psychiatric problems. For example, antipsychotic medications. The old ones which we have used in the past, they used to cause stiffness of the body and tremors, just like Parkinson's disease. Some antidepressants can cause some tremors. Similarly, there's a old drug which we don't use it much, lithium, which was used for bipolar disorder, can cause tremors. There's another medication called Reglan that can cause some tremors. So those medications, they cause Parkinson-like features. So if you look inside, there's a lower part of the brain. It says substantia nigra. That is the main part of the brain which is involved when somebody has Parkinson's disease. We think that substantia nigra is a part of the brain. When the cells are destroyed, they are not making dopamine. So the source of dopamine comes from that particular small part of the brain. From there, the impulses, they travel upwards into the upper part of the brain we call striatum. Striatum is a combination of caudate nucleus and globus pallidus and putamen. There's no globus pallidus. I'll show you another slide that has globus pallidus in it. Putamen is the center part, the orange part, and the blue part is the caudate nucleus. And the combination of this is called striatum. So dopamine goes from the lower of the part of the brain all the way from substantia nigra to caudate nucleus, and from there it goes to the upper part of the brain. So that's how the networking is starting. The main problem is in substantia nigra. For example, this one is another example. SN is substantia nigra, putamen is another part of the brain, and globus pallidus is slightly towards the center. Putamen and globus pallidus is called basal ganglia. So some people, when they have problem with anoxia, lack of oxygen to the brain, that part of the brain gets affected and they can have Parkinson's disease. The problem is not coming from substantia nigra. That's where the primary Parkinson's disease is. But problem is coming from basal ganglia, that is considered secondary Parkinson's disease. So anybody has a stroke in that area can also cause some Parkinson's symptoms. If somebody has infection in that area, for example, encephalitis, viral encephalitis, it can also give Parkinsonian features. So this is the substantia nigra where the brain main cell death occurs in primary Parkinson's disease. And the impulses from here, they travel here, putamen, globus pallidus. That's another part, thalamus. This is important I would like to talk about that because that's where we usually give a treatment for tremors also. It's also part of the process. And from the here impulses goes to this. It's a sensory, major sensory nucleus of the brain. And then they go to the upper part of the brain which controls the movement of the body. So when we move your right arm, the left brain tells the right arm or right leg to move. So the process starts from here and goes all the way up there. And if there's a problem here, then all these things are all blocked and they're affected. So similarly, it says there is a chemical imbalance because there's a cell death in substantia nigra leading to lack of dopamine because there's not enough dopamine, so there's no initiation of the movements. This is just a picture of a brain. This is autopsy actually. This is a normal brain, and this is a brain of a patient who has Parkinson's disease. So you can tell the difference here. This is substantia nigra, black part of it. All these cells, they are destroyed in this patient. You don't see this much. So this just gives you an example of this is a cut section of a brain when somebody had died and they did autopsy, and to show the substantia nigra, which you can see on the naked eye, not even under the microscope. So how we make a diagnosis of Parkinson's disease? Parkinson's disease has no diagnostic test. So history taking and physical examination is the key features to make a diagnosis for Parkinson's disease. Whenever a patient comes, I always like them to be accompanied by a person who has been with them for a few years, or they know about the history, because sometimes a patient may not tell me all the details, or they may not see things how the other person is saying at them. So it's important for you to take your loved ones or children or anybody who can give the doctor more information about you when you go to see a doctor for Parkinson's disease. History of tremors, difficulty with movement, difficulty with your gait, any falls, constipation, oily skin, all those are important features in history taking. And when I examine the patient, then we see how they are presenting themselves, how they're walking to my office, how they're sitting in the chair, how they are getting up. Is there any problem with their gait? Any problem the way they are walking? Any problem with the balancing? And also look for tremors and muscle stiffness. So during the examination, a neurologist will go into specific details about special areas where they're interested to figure out if this person has Parkinson's disease or not. Brain scans are done to make sure there's nothing we are missing. For example, I told you if somebody has small stroke, they can also have Parkinson's disease. That will help me to understand if this is a primary Parkinson's disease, is due to degeneration of the nerve cells, or is it due to stroke. So basically, scans are done to make sure other entities are ruled out. You can have a normal brain scan and have Parkinson's disease. So I know that some patients, they want to know, okay, why don't you get a scan from me and see if I have Parkinson's? MRI scans, CT scans can be normal, and a patient can have Parkinson's. Labs are done to make sure there's nothing else there's no other problems. There's no specific lab for Parkinson's disease either. So we make sure there's no thyroid dysfunction, for example. Somebody has a lack of thyroid, they can be very slow in their movements. We check for any deficiencies like B12, folate, making sure they are not deficient, because that can give memory problems and some difficulty with movement, especially with the lower extremities, with the legs. So basically, I want to stress that there's no diagnostic test for Parkinson's disease. It has to be history taking and physical examination and neurological examination. That's how we come to a conclusion if the patient has Parkinson's disease or not. Regarding treatment, there are different entities. There are medications for Parkinson's disease. The other entities are physical therapy for patients who are having difficulty with movements. Surgery used to be given to patients who were having a significant problem and they did not respond to medications. And now we have deep brain stimulation, which is another entity used so far. So talking about medications, as you know, most of you have heard about Sinemet. Sinemet is one of the oldest medications used for Parkinson's disease. It has combination of levodopa and carbidopa. Levodopa is dopamine, which we give from outside. Carbidopa is attached to levodopa so that it carries the drug to the brain, so that levodopa should not convert into dopamine in the body. We want this medicine to go into the brain and then convert into dopamine. Otherwise, it won't be effective. So Dopamine is basically given from outside because it's deficient in the brain. That's the medication usually does. It just replaces the hormone which is lacking in the brain. Other kind of medications are dopamine agonists. That means there are brain cells which are producing dopamine, but they are not enough. That's why there's a deficiency. So what these medicines they do is they go into the brain and they stimulate those brain cells to produce more dopamine. So sometimes we use combination of Sinemet and these kind of medications to have a dual effect on the brain. So we're giving the dopamine to the brain and also telling the brain to produce more dopamine so that we can use small doses of those medications to reduce their side effects. Some of those dopamine agonists are Polidel, Requip, and Mirapex. It doesn't have a list of all of them. The third kind of medications are MAO inhibitors and COMT inhibitors. MAO and COMT are the enzymes which catalyzes dopamine. Any neurotransmitter in the brain which is produced is destroyed by certain enzymes. So once dopamine is produced in the brain, there are enzymes which are going to destroy the dopamine. And these are two main enzymes, MAO and COMT. So what we usually do is give them a medication which will inhibit these enzymes so that they are not destroying the dopamine and dopamine is staying in the brain for a longer period of time. So all these medications are given in certain combinations so that dopamine stays in the brain system, in the brain for a longer period of time. So the trick is to find a right combination for each patient and figure out which one is the best for that particular patient, because there are so many medications available which can be used, but which combination is best for that particular patient is a trick. And that's how we make conclusion depending upon each patient, which combination they need for their symptoms. See here. We're going to talk about deep brain stimulation. Basically, the stimulator is put in deep in the brain, and extension is put inside behind the ear. It goes just below the clavicle, and there is a generator that has batteries. And this generator is controlled by just like a remote control. So you can send the impulses when somebody has a bad signs and symptoms of Parkinson's disease. You can stimulate, you can send impulses from here which goes inside the brain. This electrode is mostly in the basal ganglia. We talked about globus pallidus. Remember I showed you a picture before? So this stimulator is in that part of the brain. So there's a high frequency waves going in to the brain. We do not know exact mechanism of action, but we think there are certain neurotransmitters they are released and they inhibit those neurons and relieve the symptoms of Parkinson's disease, especially tremors, rigidity, and bradykinesia, which is slowing of the movements. So this procedure is available in Washington Hospital now, and we have a neurosurgeon who's able to put deep brain stimulators for treatment of Parkinson's disease. I'm going to talk about in tremors also. Deep brain stimulation is also used for Parkinson's disease. It's also used for tremors and also for dystonias. So there are quite indications for deep brain stimulation. Just want to talk about surgery. Surgeries were more prevalent. We were using more surgery for patients who were not responding to medication before deep brain stimulation, and they used to put electrodes and cause a little lesion or little hole in the brain, especially in the basal ganglia or in the thalamus, and that will relieve the symptoms of Parkinson's disease. But that was a permanent lesion. Deep brain stimulation is irreversible. You can reverse the process. If you don't want to give impulses, you can reverse it. So surgery can cause more side effects, like because speech difficulties and some memory problems. So it's preferable to use deep brain stimulation if we can, rather than doing surgery these days. Physical therapy for patients who are having great difficulty in the movement. I always ask my patients who have Parkinson's disease to exercise as much as they can, though it's very difficult for them to exercise because they have difficulty getting up and walking around, and they spend most of the time in the wheelchair or in their chairs. But the more time they're spending in their wheelchairs or at home, not sitting around and not walking, they're getting more muscle weakness. So increased activity, increased exercise stimulate their legs and stimulate the muscles to function better. Educating the family is important, and educating the patient. I always want my patients to know which medication they're using, if preferably how much they're using. It's a natural tendency for a Parkinson's patient to overuse a medication because they feel much better when they use Sinemet or other medications because they're able to function, able to move more freely. And once the medication effect is gone, they don't feel good and they cannot mobilize themselves. They have tendency to overuse the medication sometimes. And that has to be monitored because overuse of medication can cause side effects. And dyskinesias are considered the major side effects for Parkinson's medication. Dyskinesias are the term used when there's a movement of the arm or leg, and you cannot control that movement. So it's difficult sometimes to find the right dose of medication because if we use too much medication, it can cause dyskinesias, and if we lower the medication, it can worsen the symptoms of Parkinson's disease. There has to be a fine line finding the dose and the combination of medications to treat Parkinson's disease. There's some research going on to find out what we're going to have for future treatments. The gene therapy is there are some viruses which are non-infectious viruses. They're being introduced to the brain, which will change some gene mutations so that Parkinson's disease can be controlled. Neuroprotective agents are the one which decrease the they actually produce certain hormones like GABA, which is a gamma-butyric acid, which will inhibit the neurons and control the Parkinson's disease. They are not available for the public use at this point. Neural transplantation is the stem cell research, hoping that we can introduce into the brain some stem cells which will produce more dopamine in future and relieve the symptoms of Parkinson's disease. So these are the research going on at this moment. I'm hoping that in future we should have more available therapies for Parkinson's. Support group, which is in North California. This is just a phone number in case somebody wants to reach them for any kind of support. Just a famous faces, people who have suffered and have done well and for Parkinson's. I'm going to talk about tremors. There are various types of tremors. One is the biggest one I will say is essential tremors. Parkinsonian tremors, the Parkinson's tremors, which we talked about earlier. What is tremor? Any rhythmic jerking motion of the hand or of even the legs is considered as a tremor. Tremor can also affect sometimes the head or face or voice even, especially we will talk about in essential tremors. Dystonic tremor is a painful spasm and a tremor of the upper or lower extremities. Cerebellar tremor comes from the cerebellum, back part of the brain. Psychogenic tremor. Orthostatic tremors is when somebody gets up from the bed or from the chair, they have tremors. And physiological tremor. When we are examining somebody about the tremor, we examine the patient how they are doing when they're resting. If they're having any tremors at rest, or they are having tremors doing a certain posture, or when they're having tremors when they're trying to reach out for something. Slightly going back here, essential tremors, if we talk about essential tremors, these are considered as benign essential tremors. They may run in families. We do not know the exact cause of them. And they can affect the one hand, and then may affect the other hand, sometimes the legs. Some patients do have involvement of the head. It can be yes, yes, or no, no kind of tremors also. They can affect the voice, becomes very tremulous. So that's how you differentiate between other tremors. We talked about Parkinsonian tremors already. They are resting tremors and pill rolling kind. Dystonic tremor is when there is a painful dystonia, painful spasm of the arm or leg that can also cause a tremor. And once that particular part of the body is resting, the tremor goes away. Cerebellar tremors are called more intention tremors, when you're trying to intend to do something. For example, you're trying to turn off the switch on and off, that will cause a tremor. Otherwise, you're okay. Similarly, if I ask my patient to touch their finger to their nose, they may have tremors, but they are fine otherwise. It's more intentional tremors. When you intend to do something, there's a tremor, but no resting tremors. Psychogenic tremors are from patients who have some psychiatric issues. They can happen even at rest, during a posture, or during an intention. And they can be increased with stress and anxiety and lack of sleep. When you change or distract the person, the intensity of tremor may change, or their position might change, or they may go from one arm to another arm. So they vary. Orthostatic tremors are the tremors when somebody gets up from the chair and they're having severe tremors of their legs and thighs. And once the patient sits down, they're gone. So that's how we differentiate different kinds of tremors. And physiological tremor is the tremors which we think happens anyway when there is for example, somebody is diabetic and their glucose is very low, or they are very anxious, they have increased physical exhaustion, they're having alcohol withdrawal symptoms. So those are the physiological tremors. Treatment of the tremors depend upon the kind of tremors. For example, as you know, Parkinsonian tremors will respond to anti-Parkinson's medication. Essential tremors, which was the first tremor we talked about, usually medications used are beta blockers like propranolol. It's also called Indrol. Some patients, they respond to primidone, which is actually anti-seizure medication. We don't use it anti-seizure medication now, but it's used for essential tremors. I just want to say a little bit tip about essential tremors. If somebody has consumed alcohol, if they have very mild amount of alcohol use, essential tremors goes away right away. That doesn't mean they should drink, but that's a little test, because that means the brain is relaxed, the nerves are relaxed, and the tremors are gone. Benzodiazepines are the relaxants to the brain, like Valium, Klonopin, Ativan. Those are medication we use for certain population to see if that relieve their tremors. Botulinum toxin is used for dystonias only, to relieve the spasm in the muscles. Surgery is used for there has been a use of surgery extensively actually for essential tremors. A lot of centers have done surgery for patients, especially making a lesion or treating a thalamus, which is a part of the brain, and relieving the patient of tremors. Now we're using deep brain stimulation also for that purpose. And the deep brain stimulation used for using a high frequency discharge, putting the electrode in the brain, especially in the thalamus, to see that will relieve the patient of essential tremors. I guess we turn the topic to seizures. Seizure is a big entity, and there are a lot of information I can give you about seizures. I want to tell you, first of all, this is a National Epilepsy Awareness Month. November is the month of National Epilepsy Awareness. And also on October 28th, President Obama signed a bill which will protect people against hate crime who have disabilities. So that has been pending for a long time, and that has been accomplished this year. What are seizures? In the brain, there's electrical activity going on constantly. And when the electrical activity is disturbed, cells in the brain, they keep on firing more and more, and that turns into a seizure. So we're going to talk about what causes seizures and what kind of treatments are available. Just a epidemiology for that. Seizure can be just one seizure that there's abnormal electrical discharge, but epilepsy is recurrent seizures. Epilepsy can be there when the person is born because they have difficulty in their childbirth, and that can cause some damage during childbirth or anoxia even prior to that, and they're born with abnormal wiring system, and they continue to have seizures. Trauma is one of the bigger causes of seizure. Head injuries. At the time when they have head injury, they can have seizure because they can have a bleeding in the brain, which can lead to a hemorrhage stroke. Or some people, I will say, they have head injury and they may not have seizures, but they may get seizures maybe 1 or 2 years later. This is under post-head injury. Tumors, brain tumors, benign tumors, or malignant tumors can be the first feature of diagnosing a tumor. Most of the time, the patients or the families or doctors don't know they have brain tumors, but the patient will have a seizure, and they come to emergency room, get a brain scan done, and we find the tumor. So it can be first sign of diagnosing a tumor. Anoxia, we talked about lack of oxygen to the brain. If somebody stops breathing, not enough blood going to the brain, not enough oxygen going to the brain, they have anoxic brain damage. Lack of oxygen in the brain causes cell death in the brain. And whenever there's a cell death in the brain, they are irritant to the brain, and brain goes into severe seizures. This is considered a very bad prognostic sign if somebody is having anoxia and then going into seizure after seizure. Infections like meningitis, very high blood pressure can cause a seizure also. Electrolyte imbalances, that means very low sodium, very low calcium. If that is happening to the body for other reasons, the patient can have a seizure. High fever, drug overdoses like methamphetamine, cocaine, ecstasy, all those drugs, they can cause seizure. Diabetes, low glucose can cause seizure, and high glucose can cause seizure. Endocrine, lack of thyroid hormone can cause a seizure. Genetic causes, some seizures they run in the families. Idiopathic means unknown cause. That's very important. I will say 7 out of 10 people, we do not know the cause of seizure. So I always have difficulty making the patient understand. They will say, I have a normal scan and I have normal blood tests. Why do I have a seizure? You still can have a seizure, and we do not know the reason for it. As our population is growing, and we think that elderly population are more likely to get seizures, and they usually don't have a known cause. Similarly, in the other side, when infants and when they're children, like 1 to 2 years of age, we do not know why they have seizures. Similarly, elderly population, they are having more and more incidents of seizures. Some people think because they of the degenerative disorders like dementia with Alzheimer's, that can cause some scarring in the brain, which leads to increased incidence of seizures. Certain medications can cause seizures if they are given in a high doses. We're talking about seizures. There can be different kinds of seizures. They are considered as partial seizures. Partial seizures, there is no loss of consciousness. Generalized seizure, there is loss of consciousness. This is called grand mal seizure. When a person is standing, and suddenly they fall and they start jerky movements. They can have tongue bite, they lose control of their bladder, they are not breathing properly, they turn blue. That's considered a grand mal seizure. Partial seizure is no loss of consciousness, and there are two kinds of partial seizures. One is simple partial, means there's only jerking of the arm or leg, and the patient is alert and they're talking to you. There's no altered level of consciousness. They are not confused, they are not disoriented, and only having one arm or leg seizure. Complex partial is the one where there is a altered level of consciousness. They're confused, disoriented, lose a part of their conversation. They're driving around and they don't know where they ended up. So this is the most difficult to diagnose seizure, because they think that everything is fine, but they're not. Other people will perceive them that they were not with them when they were talking to them, or they lose part of the conversation, or they were staring into the space. So those are the small complex partial seizures. Only one part of the brain is having a seizure, and when that small part spreads to the all part of the brain, it becomes a grand mal seizure. So this is partial with secondary generalization. Means only one part of the brain having a seizure, then it spreads to the whole brain and becomes a generalized seizure. Some people, they do feel that they're going to have a seizure because they can smell certain, taste something bad. It's called aura, and they can put themselves in a more safer places. If they are standing up, they can sit down, and if they have a seizure, they don't have that many injuries. Motor seizures is tonic-clonic activity, moving their arms and legs. Sensory seizures is the one when they have only sensory symptoms. They can only feel numbness or tingling sensation around the lips or face, arm or leg, but no jerking. Difficulty with speech, expression of their speech, level of consciousness. We talked about altered level of consciousness. They can be confused, disoriented, not attending the conversation you're having, or getting lost if they're driving around, or loss of consciousness, which is a grand mal seizure. Urinary incontinence, tongue bite. So we think there is some relationship with change in the hormones with seizures also, because estrogens, they increase the neuronal excitability. Alcohol intake, if somebody is drinking, let's see, for years and years, and then they stop drinking, we all know there is a DTs, are called delirium tremens, which patient can become confused, disoriented, and their likelihood of having a seizure is high, especially 24 to 48 hours after the alcohol is stopped. Similarly, there are some medications, if they stop suddenly, they can have seizure. Medications which are sleeping agents, hypnotics, Valium, diazepam, the same thing, Ativan, Xanax, all those medicines which are very much highly sedating to the brain. If somebody is taking for a prolonged period of time and then they stop because they have gone to visit somebody or they're in the hospital and they're not taking medication, they can have a seizure. So it's very important not to stop your medication all of a sudden if somebody is taking that kind of medications. I talked about this high incidence of epilepsy or seizures in elderly. Status epilepticus I would like to talk about because I think it's very educational for the public to know that seizures can also cause death if they are not treated properly. If somebody has a grand mal seizure and they continue to have a seizure after another seizure, the patient is not able to breathe, and once they're not breathing, the oxygen is not going to the brain and they can die. And similarly, some secretions from the lungs can go up, some secretions from the throat, they can go to the lung and cause aspiration pneumonia. So that also impairs the oxygenation because the lungs are not working properly, because if you have eaten something or the secretions from the stomach, they go into the lungs. So it's very important if somebody is having a seizure after one after another to call 911 and take the patient to the emergency room to further treatment. This is an entity when somebody is, for example, somebody has a anoxic brain damage, they are lying in the bed in the comatose condition in one of our ICU beds, and we try to figure out what's wrong with the patient, how long we're going to treat this patient. Family is asking question, what's your prognosis is. It's very important as a neurologist for me to find out if they're having any seizures. But if they're not having seizures, obviously, and they do have history of known seizure, or I'm suspecting that they may be having seizures, then we do a test called EEG, electroencephalogram. It's a recording of the brain waves, and I might find that patient is having seizures underlying. I'm not seeing them clinically. They're not showing any symptoms, but they are in a comatose condition, but the brain is under seizures. So these are called subclinical seizures. Clinically not there. And these are usually happens in people who have liver failures, or there's a problem with their kidney functions not properly. They're accumulating a lot of toxins in their body, and that induces seizures. Or there's anoxia, lack of oxygen to the brain. Pseudoseizures are the entity which are not coming from the brain. This is mainly a problem with emotions. It's very commonly seen for people who have the seizures. So it's difficult to differentiate if they're having a real seizure or a pseudoseizure. Pseudoseizures are not treated with medications for anti-seizure medication. Depending upon their emotional disorder, the treatment is done according to that. If somebody has a seizure, which is obviously history is important, but if somebody finds somebody passed out or having some symptoms of numbness and tingling, we may think it's a sensory seizure, but we have to make sure that we are not missing other diagnoses. For example, syncope is just a passing out spell, which can happen from cardiac problems. Heart is not beating right, the blood is not going to the brain, and people pass out. TIAs, mini strokes, numbness and tingling sensation, like we talked about, some sensory seizures can have. Migraine headaches can cause you numbness, tingling, sensation of one side of the body with severe headache, blurred vision, double vision. Movement disorder, so it's like some of them, they have some movements, like we talked about all of them a few minutes ago. Sleep disorders, psychiatric disorders, so they all need to be differentiated before we make a before we make a final diagnosis for seizures. Diagnosis mainly, again, made on history is very important in this case also, because again, like we talked about Parkinson's disease, seizures, you can have normal blood tests, normal scans, normal physical exam, and you still have a diagnosis of seizure. It's very difficult for some patients to understand that how can they have a diagnosis or an entity which is going to interfere with their driving privileges, interfering with their working privileges, and they're stuck with this diagnosis. History is very important. If somebody has witnessed somebody having a seizure, that's how the diagnosis is made sometimes, because they may have normal exam, normal scans, but if somebody has seen somebody having a grand mal seizure 2 times, that means they will be under the treatment. Physical examination is done to make sure there's no weakness, numbness, incoordination. That will tell us if the patient has underlying stroke symptoms or any tumors or head injury. So those things have to be ruled out by doing a physical exam. Labs are done to make sure there's no low glucose, high glucose, low sodium, low calcium, thyroid problems. So these are considered metabolic causes. Anything wrong with the metabolism in the body itself can cause a seizure. So we look for those kind of lab test results. EKG is done to make sure there's no irregular heartbeat, because irregular heartbeat can also lead to lack of oxygen in the brain, and people pass out because of irregular heartbeat, not because of seizure. So that's also considered in the diagnosis, making a diagnosis. I will say in seizure disorder, CT scan and MRI is very important, because we do see some abnormalities which can lead to a seizure, like we talked about somebody having a brain tumor, or if somebody has a stroke, even past history of stroke or a new stroke can cause a seizure. because those are considered as scars in the brain. And any kind of scarring, any kind of interruption in the normal brain activity, electrical activity, can cause a seizure. CT scan is done, MRI scan is done to make sure there's no treatable causes which we can treat. Lumbar puncture is a study of cerebrospinal fluid by putting a needle in the backbone and drawing the fluid, and that is done to make sure there's no infection in the brain, such as meningitis. EEG is an electroencephalogram. Just like EKG is a tracing of the heart, EEG is a tracing of the brain. It's done in the hospital. We have EEG technicians who take the machine either to the bedside of the patient, or the patient can go to the EEG room to get the EEG done, depending upon how critically ill they are. We have EEG done in the ICU. She takes the mobile machine to the ICU and does the EEG by putting all the recording of the brain, by putting sleep-deprived EEG is called when the patient is sleep-deprived all night. They're not sleeping all night, but when they go for EEG the next day, then they will hopefully sleep, because when the patient is sleeping, it's more likely to show the abnormalities because the brain is more relaxed. So if we suspect that somebody has abnormality here and there, we cannot be sure with normal EEG, then we order a sleep-deprived EEG. EEG video monitoring is done for patients who have multiple seizures, and we're trying to figure out they can be helped with other measures than medication, such as surgery. And those are patients who have multiple seizures in a day. They may have 30 to 40 seizures a day, because there is something abnormal in the brain. There is something, either a growth or a scar, causing them to have seizures so many times in a day that none of the medications are working and they need to be treated otherwise. Or in some patients, like we talk about, psychogenic seizures, which are not real seizures, so they are hooked up to a video monitoring, and their behavior is monitored, and so is the EEG recording. And then the correlation is figured out when they're having a seizure, whether there's any abnormality going in the brain or not. So that also makes a conclusion what kind of seizure they're having. So if we find a cause for seizure, that has to be treated, because there are medications you can give for seizures, but if a cause is still there, then the patient will keep on having them. For example, a tumor is there, like a benign tumor is there, that has to be removed. Because if the tumor is there, it will keep on irritating the brain. If there's a blood in the brain because of the hemorrhage or bleeding in the brain, that blood has to be taken out if possible, because sometimes it's not possible when they have massive brain hemorrhage. Neurosurgeon may not be able to help the patient to get the brain, all the blood out. So most of the patients, they are managed with medication. Some people, they have intractable epilepsy, we call them, when they keep on having seizures multiple times of the day and none of the medications are not working. They are given a lot of combination of medications. Then they map the brain and figure out which part of the brain is having a focus, and that particular part of the brain is being treated or removed or during surgery. So they resect that part of the brain, or called like a temporal lobe, is very common, sometimes causing seizures. If there is a AVM is arteriovenous malformation, there is a tumor in the brain or AVM, they have to be resected. Vagus nerve stimulation is a new entity we have come up with. The stimulator, just like deep brain stimulator, this stimulator goes into the vagus nerve. Vagus nerve is near the heart, and they put a neurotransmitter in near the vagus nerve to stimulate the nerve, and similarly they have a transmitter under the skin which can be controlled with remote control, and you can send the impulses through that remote control to the transmitter, and the brain activity, the electrical activity can be changed with that stimulator. It has some side effects, like it can cause some difficulty with voice or dysphonia, but this is indicated for patients who have multiple seizures and they are not treated with medication. Gamma knife is used for treatment of tumors, primary tumors or metastatic tumors, because they are causing seizures. So we do have gamma knife here in the hospital too. being used for the same purpose. I'm going to go through real quick with the medications. These are the major anti-seizure medication: Dilantin, Depakote, Tegretol, Lamictal, Phenobarb, and Keppra. We usually don't use Phenobarb that much. It's an old medication. Dilantin is still being used. Keppra is the newest of all, and so is Lamictal. All the new medications are being used because they do not cause significant slowing of the thought process. They do not cause slowing of the memory or their motor slowing, and they have less side effects. Other medications are Neurontin, Topamax, Felbamate, which is not used much now, Primidone, ethosuximide. Dilantin, side effects can cause difficulty with the balance. All the anti-seizure medication, if they are used in excessive amount, they will affect the cerebellum, the back part of the brain, and the patient will feel as if they are drunk. It gives you the same effect as if somebody is drunk. So I tell my patients, whenever they feel as if they're drunk, it's time for them to get the level done. That means they are toxic on their medications. And the usual dose is 300 milligram a day. Tegretol is also, there are certain medications, they have blood levels, such as Dilantin has it, Tegretol has it, Depakote has it. So I can check how much medication they have in the blood system. When I'm checking for the compliance, means are they taking the medication regularly or not? If the blood levels are being monitored or not. In certain populations, it's very important. And medication like Keppra or Lamictal has no blood levels, or there's no correlation with the blood levels with effectiveness. Depakote is anti-seizure medication. It's also used as one of the major mood stabilizers. So a lot of patients, they have some patients who have neurological problem and psychiatric problem, they end up having this medication, Depakote, which can be used for two purposes, as a mood stabilizer as well as anti-seizure medication. Status epilepticus is just a entity to make sure that if somebody is having a seizure after seizure, they have to call 911, make sure, start the medications right away to stop the process so that they will not go into a significant problem. When somebody is having a seizure medication, they have to take the medication regularly. If they stop the medication in the next couple of days, the blood level can drop and they can have a seizure. So it's very important for a patient to understand, because I will give them a 1-month prescription and they'll come like, oh, I didn't get an appointment with you and I stopped the medication. So either they have to get an appointment earlier or they can call the pharmacy to get the level, to get the medication refilled, because they cannot stop the medication once they're on it. Because their likelihood of having another seizure is much high, because they are withdrawing from the medication itself and they are not protected with medication. So it's very important to take the medication on a regular basis and get their levels checked and look for the signs which can cause some toxic side effects. If somebody is having a seizure, we do not want them to drive. If somebody has seizure, they come to emergency room. It's doctor's duty in the emergency room to notify DMV that the patient had a seizure, and they have to be cleared by a neurologist, getting all the tests done to make sure they are not at risk for having a seizure, because if you have a seizure on freeway, or your likelihood of killing yourself and killing others is very high. California laws are very strict, and they are being monitored quite closely. Somebody is having a seizure on highway can cause a significant problem. When somebody has a seizure, they can have injuries, aspiration pneumonia. We talked about the food from the stomach, or excretions going into the lungs, difficulty in breathing leading to death. If somebody has seizure and they drink excessively, or they're having 2 or 3 drinks, the brain relaxes and more likely to cause a seizure. So alcohol can actually lower your seizure threshold. So we do not recommend patients who are having seizures to drink alcohol because of the same reason. Sometimes lack of sleep can trigger a seizure. It cannot be the cause of seizure, but if somebody has a seizure and they are not sleeping properly, they can go into seizures. Fever and can also cause a seizure. Anybody has a seizure, we do not want them to swim for a while, making sure that their seizures are under control. So is driving. Protecting themselves from the fall. When somebody is having a seizure, you can loosen their clothes, roll over to one side so that they will not take the secretions from the mouth to the lungs. So still is considered a stigma, even though we have a lot of education about seizures and epilepsy. This is just a DMV issues. Some people do have seizures at work, and then it's very difficult for them to go back to work because they have to be cleared to make sure they're not going to have further seizures, because if the employer also feels that they're liability if somebody has a seizure and they get hurt on the job. This is support group for Epilepsy Foundation, and we are done. Thank you.